All right, Suzanne, let's just start with the basics for people that don't know what a perioscope is. What is a perioscope exactly?
A dental endoscope is a small fiber optic camera that it goes below the gum line and it provides real-time video imaging on a chairside monitor. The fiber optic cable is less than a millimeter around and it attaches to what is called a dental endoscope, which is a small probe-like instrument, is what the fiber optic cable fits into. And then it is placed below the gum line and real-time imaging shows up. It allows operators to view uh, below the gum line, and they can diagnose and treat simultaneously.
Mhm. And what are some of the other components of the actual system? I know there's a monitor, there's a water system, and so forth.
Right. There are five main components of the endoscope. The endoscope has the MCU or monitor. The monitor is what we use in the new perioscopy system. It's a 17-inch medical grade monitor, and the little circle where we can see inside the monitor it's almost 6 inches. It's about 5.5 inches around compared to the older model, which was 4 inches in diameter. So it gives us about a 25% larger viewing area. There is a base which holds the monitor, the MCU in place, and then there's a self-contained pressurized water unit. You have to have pressurized water constantly, a water flow running over the lens of the camera. And the reason is because when we put our probe underneath the gum line, if we didn't have a constant source of lavage or something flowing there, air, water, it would bacteria, blood, debris would come back onto our camera lens and it would obscure our vision.
Hmm.
Then the other part is we have our fiber optic cable. The cable is about 3 feet or 1 meter long. So when we're working, we're pretty well up close and personal. We have our monitor, and then we have our fiber optic cable that is attached to it. And each patient receives a sterilized sheath that covers the fiber optic cable so that we prevent cross contamination. And then we have 2 foot pedals. You have 1 foot pedal that you've got your foot on to allow constant water flow over your lens. And then the other foot pedal that we're using is for our ultrasonic, so that when you're visualizing underneath the gum line, if you have bacteria debris that shows up on the root structure, you're going to want to remove it at the same time. That's the beauty of endoscopy. It allows you to diagnose and treat simultaneously. When DentalView first got started, DentalView were the original manufacturers of the endoscope. And when they first got started, the way that they taught was to view, instrument, and view. And so what you would end up doing is you would take your camera, put it down underneath the gum line, see what you could see, take it out, put your ultrasonic in, work it around in there in the area where you thought you were, take your ultrasonic out, put your camera back in, and see if you got it. And sometimes it took upwards of an hour.
Yeah.
And so, right, and so that has evolved to what is called two-handed perioscopy, where you view and instrument simultaneously. It's the most efficient way of working endoscopically. That's how they do it in medicine. And so dentally, we've followed suit.
Does the system have its own water pressure? Because I know, like when I attach my air polisher to my chair, sometimes the pressure is different and it's inconsistent. How does that work, Suzanne?
Yes, and so when you have a pressurized water system, typically the way that the old system was for the water, and this is one of the reasons that the old DB2 failed, was because when you hooked your water supply up to the unit, each pressure was different. And so with a self-contained pressurized water unit, you hook it up to the air. You have what's called an air quick connect, and that's what pressurizes the bottle. We set our bottle at about 60 psi, and so that allows for appropriate water flow. And then, of course, we have a knob where we can dial it up, or the water flow up or down, just depending on what we need. But we typically like to be right around 60 psi.
Hmm. And what are some of the advantages? I mean, it's pretty obvious, like you said, Suzanne, as far as direct vision of calculus and other debris. besides that, I mean, that's pretty much the primary advantage, and diagnosing things and other stuff, right?
Right. And so that is the primary advantage. That is typically why people use an endoscope, is because they want to be thorough with root debridement. When we leave accretions behind, then our patients are not typically going to heal optimally, because what happens is everybody has their own tipping point of it's the host factor. It's where our body will tip over from health to disease. And you can have two different people that can have the exact same amount of a bacterial load, but if one person has a more compromised immune system or host response, they're going to tip over disease faster. If we can make sure that we can remove the deposit, if we can see it to remove it, chances are our patients are going to heal optimally. At least we know that if they're going to be diseased or continue to have disease, it's not going to be because we have left deposit behind.
And plus the reality too. I mean, no matter how good of a hygienist you are, I mean, you're gonna leave stuff behind. I mean, probably, I would say 5 millimeter or beyond, you're gonna leave stuff behind.
Pretty much. A lot of the studies that have been done are really around 4.5 millimeters. You know, I say the benefit of the doubt when I speak. I use a little clicker system. It's kind of fun, and I always ask people, what is the deepest you can clean non-surgically on a single rooted tooth, and then they respond. And the reality is it's around 4.5 millimeters. And so when you think about it, as dental hygienists, we see patients with pocketing that is much deeper than that. And the studies show that, you know, around 5 millimeters, we're pretty well capped out. There was a study that was done by Rabbani, Ash, and Kafesi, and what they found was that, of course, pockets that were less than 3 millimeters were the easiest for effective scaling and root planing and biofilm removal. Pockets that were 3 to 5 millimeters were a little bit more difficult, and pockets that were greater than 5 millimeters were the most difficult. And that for calculus removal, and it didn't matter if you were working on a single rooted tooth or a multi-rooted tooth. So it's pretty well 5 millimeters, and the average length of time for the scaling was about 20 minutes per tooth. I don't know very many hygienists that get to use 20 minutes per tooth. So
That's right. Yeah, plus too, I always think about this, Suzanne, like if you're like scaling supra and you can visually see it, you're very efficient with your scaling. Whereas if you're blind scaling, you're basically going over the same spots over and over to make sure that you're getting, or trying to make sure that you're getting it. So you're kind of like almost wasting time and strokes because you can't see, right?
Right. Yeah. And so you're not as efficient as you could be. When you can visualize it, you can see it to remove it. That's exactly right.
Plus, if you're hand scaling a lot and you're root planing and you're just taking away cementum and so on and so forth, because you're just going over and over and over again. So
you're going to burnish calculus. The one thing that I will say about the endoscope is we don't use hand instruments at all. That's not the method that I teach, and it's not the method that was recommended to me when I learned how to use it. And the reason is because you don't have to. If you can see it to remove it, you don't need to do that. And it's unless you've got tissue that is incredibly boggy, you don't have the space to put a hand instrument and your camera down there at the same time. So we have ultrasonics now that are very thin, probe-like ultrasonics. They're going to be the most effective method for removing it. I know that one of the questions that has come up frequently when people have asked me, they said, well, what kind of ultrasonic should I use? Should I use a piezo? Should I use a magneto? And the reality is it doesn't matter what is comfortable in your hand. For me, personally, I like the magneto. I was trained to use both a magneto and a piezo, and I've gone to the magneto. I like the magneto because I think that it's easier for me. Unless you've got a lot of money that you can buy extra handles for the piezo, you're going to have a lot of screwing and unscrewing to do with the little tips.
Yeah.
And with the magneto, for me as a clinician, time is always of the essence. I don't have a lot of time. And so I want to be as time efficient as possible. I find that when I can just take my magneto insert, put it in, boom, I'm done. I'm ready to rock. And I can do basically the whole mouth with just one universal. Although I will say I love my rights and my lefts. I use them in deeper pockets. I feel that I'm more effective. And I also love a very fine diamond tip. Oftentimes we'll see deposit that is embedded into the cementum, and using a standard ultrasonic makes it difficult to remove. When you can get in there with a fine diamond tip, you can use very low pressure and very low amplitude, and it will take it right off. So I love it. It's a great little tool.
Yeah.
It is advanced instrumentation, though. I would not recommend using a diamond without an endoscope.
Oh yeah, yeah. I've tried different piezos myself, different brands. I mean, they're okay, but I like my magnetostrictive style. I don't know why. It fits me better than the piezo.
Yeah.
Me too.
Same here.
And I like keeping things simple myself too, Suzanne. I do have left and rights, but I like my just one. You know, if I can use one and get away with it, that's the way to go. But,
Yeah. Now you wear loops. You wear pretty significant loops, don't you?
yeah, I wear 4.5 loops. Yeah.
So how is that for you with magnification? Because I know that I wear loops as well as when I use my scope. So I'm interested with you and the 4.5.
Yeah, I would say probably 4.5 is the max for a hygienist. They push 2.5 in school for hygienists, but I jump right to 4.5 after about a year.
Wow.
And for me, like, you know, when I'm doing scaling or root planing or just debriding in general, you know, if I use air and I blow back the gums a little bit and I can look down a little bit, I can see, you know, not all the way down if it's a deep pocket, but, you know, a little bit. So it definitely helps to visualize it directly, but no way close to a perioscope, obviously, but it definitely helps, that's for sure.
The magnification with the endoscope is 24 to 48 times, just depending on how close you are to the root structure. So it would be just like using a microscope. And it's interesting because when I teach, the one thing that I constantly have to tell clinicians is that I want them to use micro movements under the microscope. When we're in school and we learn how to use the cavitron, we're taught with these big, broad strokes. And when you use an endoscope and you get in there, you can't use these kind of strokes because if there's deposit, you need to slow it way down and take smaller strokes over that in order to remove it. I like to use the lateral border of my tip and the first, 1 to 2 millimeters, and I find that that is very effective, just going very slow in order to remove it. The other thing that's pretty interesting is that biofilm is very sticky, and to visualize the biofilm on the root structure, you can't use a broad stroke in order to remove biofilm that's sticking to the root structure. You really need to slow down and take your time. And it is amazing how hygienists said, well, this is the way that I do it. And I say, okay, you go ahead and debride and let's take a look.
Yeah.
You can't believe how much deposit is left behind. To me, that is one of the best tools for learning, is to actually be able to visualize, to see.
Yeah, I think it's natural for hygienists to, like, once they're debriding blindly, they tend to speed up, because they're not seeing what's going on. But when they when they can see it, they're more, they're slower. They slow down. It seems like, at least. Can you talk a little bit, Suzanne, about as far as basically selling it to, like, if you're an employee or if you're maybe somebody coming in as an independent person to working with a periodontist or something, just to kind of selling it to them, like the idea of the perioscope. Is that a difficult challenge, I would think? Or
there aren't very many independent hygienists that have a scope and basically provide that type of service where they go in and provide perioscopy. There are some outliers. Lynn Groff in Southern California is one of them. She started a a mobile scope business, and the name of her business is Pocket Resolution. And Peggy Cheshire in Nevada, she also started a perioscopy business. And I will tell you, it is a hard road to hoe. I mean, it's tough. But most hygienists that use the scope work for a dentist in the office. And so it is the dentist that typically buys. I purchased my own scope, and I'm glad that I did. I'm thrilled that I did, because I wouldn't be where I am now if I didn't. But I think that most hygienists that use the scope work for a dentist, not independently.
So it's mostly a general dentist, not periodontist?
No, I will say periodontists are typically the ones that purchase. And to me, I'm so glad that we have a new scope now, because previously, I don't think the scope sold the way that it did, because there was such a steep learning curve with the instrument view type of thing. But now with the new scope, things have come along. Visualization is so much better, and we have people. We give them all of the basics in one day, and then what they need after that is practice, just to get better. So removing deposit is what we do as hygienists. And in a perio office, what it does is, when you use the endoscope, it allows the hygienist or the hygiene department to separate themselves from the general practitioner, because oftentimes we hear, well, what is it that makes the hygienist in general practice better than the hygienist in the perio office, or vice versa?
Yeah, right.
And it's because if you have equipment that allows you to provide better instrumentation, then that sets that office apart. Unless you have a large office, general practice where you see a lot of perio patients, you can use an endoscope in general practice and do very well, because you can prevent your patients from having to go to a periodontist by catching it early, treating it early. Sadly, oftentimes by time perio offices get our patients referred to us, they're a train wreck. And so I'm going to say, if you can nip it in the bud early, it really is in the best interest of the patient.
Yeah, because right now for me, Suzanne, like I basically stick with 5 millimeter or less. Beyond that, I try to refer out to a periodontist. And like over the years, like in the beginning, it just seemed like in hygiene school, they were all for us, debriding 9 millimeters, 10 millimeters. But the longer I do hygiene, the more I think I can't do that. I can't do that blindly. It's
right.
Not,
That's right. Good for you, Mark.
Yeah. So yeah, five or less. That's it. That's it for me, pretty much. Yeah. So I've been thinking about doing this for a long time, Suzanne, as you know. I'll probably do it eventually. I have so many things I'm working on, but my idea is to probably approach a bunch of periodontists in the area and see if they'd be interested first, because I would like to. I mean, if they just hire me as an employee and maybe like split the fee or something, I don't know, something like that, where there's no risk for them, because I would just come in, I buy the perioscope, they just give me a high percentage, something like that. Does that sound like an idea, you think? Yeah.
I do. I think it just depends on what they want. And, I think the hardest thing is a lot of doctors are concerned that by going in, I wrote a business plan because that's what I did. I pounded on 1,000 doors, and I will tell you, it's tough before you find those few that say, yeah, come on in. And that's what I was very, very fortunate to do that, because first I started out with a general dentist saying, I can do this. I bought my own endoscope, and the doctor that I was working for at the time had 2 offices. He had no interest whatsoever to have the endoscope even in his office. And so I thought, well, here I bought this equipment. I want to learn how to use it. I want to be good at it, because I knew that it would benefit the patient. So I started to knock on every door that I could in the whole entire area, and I got turned down a lot. You got to have a thick skin.
Oh, yeah.
And so I turned to periodontists, and I finally found 2 periodontists that were willing to take me on. I worked Tuesday, Wednesday, Thursday general practice, and on my Mondays and Fridays I would go to the perio office, and I just continued to work at it. And interestingly, I knew that my husband was going to be retiring, and so I wanted to be able to share what I had learned with others. And so I told Dr. Kwan, he is the president and CEO of Perioscopy Inc., that I wanted to become a trainer, that I didn't know how long I was going to be staying in the Seattle area, but that after he retired, I wanted to be able to share. So I flew up to San Francisco from Seattle, and I spent a couple of days with Dr. Kwan, and he trained me to be a trainer. And this was in 2010. And after I got back from that trip, the doctor that I had been working for in the office that I'd been in fired me. And typically when one gets fired, they say, oh, no, this is terrible. This is the worst thing that could happen. For me, it was the best thing that could happen. I went home and I sang home. I was miserable in that office. I didn't get to do what I wanted. Mm-hmm. Tuesday, Wednesday, Thursday were my countdown days where I was working in general practice. Mondays and Fridays, get to going to the perio office to use the scope is what I lived for. And so I went home and I saw an article on perioscopy when I got home, and it was like, okay, I'm going to do this, and I was excited, and it just took off from there. Within 4 days, I was employed with a periodontist, and he was flying me from Seattle to Eastern Washington to work for him every other week to do perioscopy. I was like, oh my gosh, my life changed.
Yeah. So do you work in Georgia too, Suzanne?
I do not. We moved, my husband and he retired, and I continued to work, actually, because I wasn't ready. I tried after a year after he'd retired. My husband said, okay, stay home with me now. And I was so miserable. My boss said, come back to work. My husband said, go away, go to work. Yeah. So he continued to fly me from Georgia to Seattle every 6 to 8 weeks for a week. And that's a long commute, but I absolutely loved it. And then at the end of May last year, I gave up my clinical job. I have become a speaker, and with my training, it has just really kept me busy. And after moving to Georgia, I started to work with the Hygiene Association, and I became the chair of governmental affairs for the Georgia Dental Hygienists Association. Mm-hmm. And having moved from Georgia, from Seattle to Georgia, oh my gracious, I was so glad to be able to work with them, because now we have a bill to allow us to do anesthesia, local anesthesia, where Georgia is one of the last states in the nation that don't allow that. So I'm happy to be working with a group of women and men where we can actually try to progress there.
That'll be good. To me, that's just like basic stuff. I mean, every hygienist should be able to give local, at this point. It's ridiculous.
Isn't it? Oh my gracious.
Yeah, it's ridiculous. So how you split your time now, so you're basically training and you do seminars and that kind of stuff and presentation?
I do. And my trainings take up a fair amount of my time, and it just depends, when Dr. Kwan sells a fair number of scopes, then we set up the trainings, and I travel all over the country, and I love that. I get to meet a lot of different people in a lot of different offices, and I like that. I enjoy that, and I love teaching them what I know and watching the light come on. Bing, and it's like, oh! So that's very fun. In fact, I'm flying out tomorrow. I have an office that I'm going to be training in Minnesota, and tomorrow I'm down here in Florida. My husband and I live 6 months in Georgia, 6 months in Florida. So I'm right here on the beach in Florida, and tomorrow is supposed to be 78, and I'm crying because it's going to be minus 11 in Minnesota.
Yeah. That's my world right now. Yeah.
Is that where you are?
No, I'm near Boston, but we have all that snow, and
right.
I was shoveling snow off my roof today.
Wow.
It's going to rain. It's going to get heavy on the roof, so.
Yeah, be careful with that.
Yeah. So let's talk about the price of the system, Suzanne. How much it is?
Okay.
How many are being sold, right now, the new ones and all that kind of stuff.
Right. Dr. Kwan used to sell the older endoscope, the DB2. People would want to sell it, and we no longer support that as far as selling it. And so the only product that is being sold from Perioscopy Inc. is the new Perioscopy system, and that's $22,000, and it comes with the training, which is nice. So it's very important when people, if they haven't used a scope before, it isn't a piece of technology that I would suggest, yes, just sit down
And play with
just
it.
do it on your own. Right. And so it comes with the training, and I think that that is the best way to get people off on the right foot. So,
And how long is the training? Is it one day, you said, all day?
it is, and I spend the entire day with them. We start at 7:30 in the morning, and we end at about 5 o'clock that night. We start with what's called bench work in the morning. I have a typodont, and we use that, and then the typodont is the model of the mouth, and I get them started with just visualizing. Then we go to the two-handed technique. We have 3 patients in the day, and that's nice because I'd like for them to get in every quadrant of the mouth is what our ideal is. Typically, I like to recommend that our patients have between 4 to 6 millimeter pockets, but any pocketing really above 4 millimeters is very difficult to scope in a shallow pocket, and so it really is ideal for pockets that are 4 millimeters and greater.
And you were saying, Suzanne, is it mostly periodontists buying them right now?
It is.
Yeah.
It is. Almost every office that I'm training right now is a perio office. The new scope came out in October of 2013, and by next month, 80 scopes will have been sold, 80 new scopes, which is in 1 year. That's great considering that the older scope, the first DB1 came out. Oh my gracious, this thing looked like
It's like
it was
2001, right? Yeah, something like that.
no, I'm sorry, in the late 90s,
Yeah.
the first scope came out, and that was called a like the DB1, and it was giant. It was huge, this thing on a cart. And then the DB2 is what most people are familiar with. So the new perioscopy system is much leaner. It uses the medical grade monitor. The old one looked like an old computer with a fat back. You know what I'm talking
Yeah. Yeah.
and this one is much sleeker. I really like it, and I'm very fortunate because I not only have the older model that I purchased for myself, but I have the new demo unit, and it's fun for me because when I have opportunity to go to seminars, I like to bring the demo unit with me so that my attendees have opportunity to play with it. So that's a lot of fun for them. It's an eye-opener. People think, oh, I can do that. I think if you're a great drummer, then or video gamer, you're probably going to catch on a little bit quicker.
Yeah, my thought has always been like once I try it, I probably don't want to go back. Like I don't want to scale blind ever again, right?
I'll tell you, it's the truth. Almost every clinician that really gets into using the scope, they would never want to go back to blind instrumentation. I know that I wouldn't, and that's the thing that I hear from so many other scope clinicians. True. Once you've done it, you never want to go back again.
How do they typically bill for the service? Do they bill for the scaling and root planing and then add like a 49.99 code for the perioscope, or how does that typically work?
That's a great question. In the offices that I've talked with and worked with, oftentimes because most of the doctors are they accept insurance, and so they have a fee that they charge for their 4341 or 4342, and then they add a consumables fee on top of it. You can bill it out as a 4999. You can bill it out as an irrigation because you constantly have a source of lavage. The reality of it is that is typically not going to be covered by insurance.
Right.
And what we do is we just like to tell our patients, this is the fee for scaling and root planing. Your insurance is going to cover so much of it, and this is what your out-of-pocket expense is. And typically, the out-of-pocket expense is still much less than what surgery would be.
Yeah.
So as we know, scaling and root planing is the gold standard in therapy for initial therapy because that is what is going to allow us to evaluate what really is going to need further treatment. So by being able to provide very thorough debridement on the front end, we're going to know what needs further surgical intervention or not. And
Hmm.
oftentimes, people, if you can catch it early enough, you can get them to heal well, and they don't need further treatment, just regular supportive periodontal therapy every 3 months.
And I would assume that most people, probably all of them that have a perioscope, they probably don't offer like two options, perioscope, no perioscope, right? It's probably no. The way we do it is we use a perioscope, right? That's pretty much how it works.
And that's the usual and customary in their office. When after I purchased my scope, after I got fired, and the doctor he was flying me over to Eastern Washington. We didn't even offer scaling and root planing without it. It's why would you want to do something that you know is not as effective? And so when you have technology that's going to allow the patient to heal optimally, you're going to want to incorporate it.
Hmm. Yeah, exactly. Like we are just saying, once you use it, it's probably tough to go back. Like, why would you want to, you know, it's like
Right.
it's like hand scaling only. Then you get like a power scaler. You're like, why would I want to go back to hand scaling?
Exactly.
I
Exactly.
don't want to do that. I don't like hand scaling either, Suzanne. I very minimal hand scaling, but I power scale for the most part, then go back with hand scaling a little bit. But let's see. I think I touched on everything here. Oh, as far as the training, so yeah. So you travel to the office, right?
I do.
That bought the periscope. Right. Okay.
Right. And so I'm the one that travels. They just need to get their patients, and I send them a list ahead of time. So we're in communication from before I show up. And I tell them what kind of patient that they're looking for, the pocket depths. I actually lay out the scheduling for the day. And our patients receive a certificate of completion, and they also receive 10 credit continuing education credits. There's
Hmm.
about 2 hours of video that I like for them to watch prior to instruction, and that can be found on Dr. Kwan's website.
Hmm.
And it's about 20 videos, and that allows attendees or clinicians that are going to have training to review all of the pertinent information before we actually start with hands-on.
Hmm.
So I use those 2 credit hours as part of their 10 CEs. And since I'm there with setup at 7:30 in the morning till 5, so it's a nice way to get comped for your CE for a day.
Yeah.
And just depending on whether your state laws allow that.
Right. Right. Is there a waiting list for periscopes right now, or is it?
Sorry, my phone's going
It's
off.
all right.
I think that when people put in their order, they can get their scope within 2 to 3 months.
Oh, that's pretty quick. Yeah.
It is fairly quick. We
Yeah.
build them when the orders come in.
Hmm.
So, yeah, so we'll have almost all of them we build from scratch. And
Hmm.
so when the orders come in, then we just start to fill the orders. And that's nice because when we let them know you can expect your scope in 8 weeks, then I get with them and say, okay, let's take a look at the calendar, let's choose a date, and it allows them to make plans for that time to review the video. And then the other thing that we like to do is have people ahead of time start using their non-dominant hand. When you use your endoscope, you have your dominant hand using your ultrasonic scaler, and you have your non-dominant hand using the endoscope explorer. And so there's a muscle here. And when you're holding something like this, remember when we first started to use our mouth mirror,
Hmm.
your hand would fatigue? Well, when you're using this in the pocket and you're also trying to retract at the same time, your hand fatigues. And so I find that when people start using their non-dominant hand more frequently, it's going to build up that muscle. And so I like them to start to do that. So they have about 8 weeks to prepare.
Hmm. Very good. Um, so what are some of the seminars you do, Suzanne? Is it just perioscopy, or is it other topics that you do? The
When I,
seminars.
When I speak,
Yeah.
I speak on a number of topics, and mostly perioscopy. It's for the offices that have me come train. A lot of them like for me to. They have study clubs because they are perio offices, and so they like to invite their referring doctor over along with staff members in the evening after training or the day before training, and I will do about a 2-hour presentation for them, just
Yeah.
run through the basics. I like to show some cases and diagnostics. So we talk about perioscopy, calculus removal. I show them cases like that, and then we talk about subgingival anomalies and pathologies and show them slides that can also affect patient treatment outcomes. If you can't see it, you can't treat it.
Yeah.
And when you see root fractures, you see perforations. Oftentimes, we will see things that will show up with our endoscope long before they will ever show up radiographically. Our referring doctors love that,
Yeah.
especially if we're in older restorations, that type of thing. We can see if there's leaking margins. We can see if there's recurrent decay. When you have a plaque trap, things
Yeah.
like that, the tissue is not going to heal optimally. So when we see these things that need to be addressed, we just refer them back over to our referring doctors, and they love having this information. We can also record from the scope, and I do that frequently. I like to record because then when we see something, I can capture a still from my recording, and I can send that back to my referring doctor.
That's cool. Yeah, some of the cases that I've seen you post, Suzanne, like you basically, for the most part, just clean, debrided basically, and some of the results were pretty dramatic, like some deep pockets, 8 millimeter, 7 millimeter, you know. Yeah, it's pretty amazing actually.
Thank you.
Yeah.
I love getting cases from people that I've trained throughout the years, and I, Dr. Kwan and I'm sure others like to share their cases, and so seeing the results when we were at the AAP in September, the American Academy of Periodontology in September. I was there working the floor at the AAP, and we had a video going and also showing some cases. And there were some clinicians there that just had amazing results, amazing bone fill. And I like to show different cases using different adjuncts because people will ask me, well, what about Arrestin? What do you think
Yeah.
about this? Well, I have a perioscopy and Arrestin case. I have a perioscopy and a laser case. I have perioscopy and povidone iodine and just perioscopy and antibiotics.
Yeah.
And the results on all of them are amazing. But the common denominator is that they all have been meticulously debrided with the endoscope. So which one is it? Is it the chicken, the egg? You know, what is causing this?
Chicken.
And, right, exactly. So
Yeah.
I think the basic getting, and this is why the endoscope is wonderful for perio office because it's getting back to basics. You know,
Yeah.
when you can get the root clean and we can get our patients to heal optimally, we can keep them from having to have surgical intervention.
Mhm.
So I think that it's well suited for that.
Do you have any brands that you recommend as far as the power scaler or tips, that kind of stuff?
Not really. I do like the Tony Rizzo Diamond. I will
Yeah.
say that I like it because it's thinner. It's a much thinner tip. I have used the Densfly, and it is a fat diamond, and I don't like it at all. I think it's very aggressive. So when I do use a diamond, and again, I would only use that with the endoscope for visualization because it is aggressive. I like the Tony Rizzo. And typically, I like the external, when I'm using the scope, I like the external water flow instead of the internal because of the spray.
Right.
And so when you have that spray going on and it's coming back on your lens, it makes visualization difficult. At least that's what I have found. So
Mhm.
I like the external water flow, which is basically the old metal kind. And that can also be found with Tony Rizzo. Another wonderful place where you can find ultrasonic tips where they retip is Mad Ultrasonics.
Yeah.
And I like that. I like those because you can just tell her what you want and she can do that for you.
So do you basically use like long, thin tips for the most part?
I do.
Okay.
I do. I
Yeah.
very seldom will I use a heavy tip
Yeah.
unless there's really heavy deposit when I first get started. What we like to do is when we're going to do a quad or a half mouth, and I typically like to do half mouth at a time.
Mhm.
So I will numb the patient up, and then while they're getting numb, I'll get in there, debride the area quickly, knock off any big chunks, and then jump right in with the endoscope. So if there's a lot of heavy deposit right away, I like to use a heavier tip going through the first time just to knock off the big chunks, and then I can focus in when I have visualization.
Mm-hmm. Have you tried the Parkel Burnett power tip?
No, and I've seen that. Do you like it?
That's what I use basically. But 80%, 90%. I have that, and I have their version of the Perio tips and the right and left. I don't use the right and left too much. Just the power tip. It's not like super thin, but it's like a little thinner than a typical universal, and it's long and it's powerful.
Well, I'm
Yeah,
going to have to check it out because
yeah,
I like long and powerful.
yeah. That's what it is. So, I mean, I've taken off a lot of things with that thing, you know. So
That's
yeah,
great.
it's definitely nice. But I don't know if it's maybe too thick in some cases. Like if you're I don't know if you were working like on a distal of 31 or something, and you had like a 6 or 7 millimeter pocket. I don't know if it would be a little difficult with that, but I mean, other than that, it's pretty good overall tip, I think. Yeah. Yeah, let's see. And also too, so I wanted to ask you about having the Perioscope Explorer in there with the tip. I mean, do you find any areas of the mouth where it's tough to get in there?
I'm so glad you brought that up because
Yeah.
I was just going to tell you if there's the most difficult area is for me the maxillary distal of the second or third molars. Oh my goodness.
Hmm.
Getting in there is very difficult. We have the same anatomical problems that clinicians do when they're scaling blindly. If you've got people that can't lay back very far because of the water flow, you've got
Hmm.
gaggers, people with small mouths, giant tongues.
Hmm.
The giant tongue, that'll push you right out of the mouth. So we have all these same anatomical considerations. But for
Yeah.
me, visualizing a deep pocket on the distal of the maxillary second molars, I find it's challenging. And then I find that I spend proportionately more time on my maxillary molars than I do on my mandibular molars when they're periodontally involved because I have more root structure to cover.
Right.
So
Yeah. So it's a challenge either way.
it
Yeah.
is. One of the things that I absolutely love to do, though, when I'm using the endoscope is something called cross instrumentation. And
Hmm.
what that does is it allows you to use your camera from one side of the tooth so you can visualize, especially when you're going interproximal. So if I had my camera from the buccal, I can
Right.
see interproximal. I can come in with my ultrasonic
Yeah.
from the lingual and I can visualize and clean that way. And I really like that because you can get right up underneath the contact point and into the CEJ. The most common place where deposit is left, believe it or not, is at the CEJ. There's a
Right.
natural little depression there, and hygienists want to run right down to the deepest part of the pocket. They completely miss that. So in the interproximal area, I can really see that when I'm cross-instrumenting, get right in there and smooth that out.
Hmm. Very good. All right, Suzanne, do you have anything else you want to add? I think I hit all the points I had on my list. So.
No, other than if I can provide any other information, I do have a website. It's called perioscopyprofessionals.com. Dr. Kwan's website is perioscopyinc.com. You can find information on the DB2 for support. We still have the old manual on there for the DB2 for people that have purchased one and want support. So he provides the old fibers, and you can purchase because the endoscope tips, the endoscope probes,
Yep.
explorers,
Yeah. Yeah.
sorry,
I gotcha.
are for the old scope as well as the new scope. You can purchase those as well.
Hmm.
So everything that you need for the old scope is still available. And the Aubrey group is the group that used to provide support for the old scope when it went down. And I'm not sure if they're still available, but that information is on Dr. Kwan's website.
Yeah, I'll have both those websites, those links on my blog post. Once I blog, I post all this stuff, so people can just go to the blog and find all that. So, all right.
Great.
All right, Suzanne. So I want to just stop recording, but just stay on for a second, okay?
Okay. And I want to say thank you very, very much, Mark. I've enjoyed talking with you and being able to tell the world about perioscopy.
Yes. Hopefully I can meet you in person.
I would like that.
All right, here we go. Let me stop here.